Thank you very much. Today I am presenting the rare histology of endometrial cancer. A 66 years old postmenopausal multiparous female presented with postmenopausal bleeding since 5 days at the time of presentation. Bleeding was of moderate amount associated with white discharge. There is no history of pelvic pain, fever, bowel and bladder complaints. So she had CA breast, invasive breast carcinoma grade 3, T2N0M0, ER positive, PR negative, HER2 positive of the left breast in 2015. She underwent MRM followed by 6 cycles of adjuvant chemotherapy and hormonal therapy with tamoxifen for 2 years. Now on letrozole. There is no other comorbidities and there is significant family history. Mother had CA pancreas at the age of 78 years. Sister had CA endometrium at the age of 64 years. On physical examination, there are no supraclavicular nodes felt, no palpable inguinal nodes, per abdomen soft, left breast mastectomy done, scar present, opposite breast is normal, per speculum examination, cervix vagina normal, PVR uterus bulky, bilateral adnexa, no mass felt.
Now, last panelist, what will be your approach at this level? Dr. Pabarshi?
Yes, I can hear you. Yeah. So for the case who is a postmenopausal bleeding PV with a history of CA breast and obviously an intake of tamoxifen, I would like to go ahead with an ultrasound pelvis, preferably a transvaginal ultrasound if available, to look at the endometrial lining and if any lesion is present. If there is any presence of lesion, I would prefer to do an office endometrial biopsy to look at the pathology.
And okay, go ahead, Dr. Raveena.
On investigations, ultrasound abdomen and pelvis suggestive of bulky uterus, 9 centimeters into 5 centimeters into 6 centimeters with endometrial thickness 27.5 mm. Papilla endometrial biopsy reported as fully differentiated malignant neoplasm with focal glandular pattern. Following MRI pelvis done, the uterus measures 6.1 centimeter into 7.9 into 7.1 centimeter. As we are showing the first image, that is T2 sagittal view, and our anterior view is intact and posteriorly distorted. Half of the myometrium is invasion, more than the tumor is filled with the myometrial invasion. So we can see this is a T2 first image, and second section is axial section, and endometrium is thickened and seen breaching the anterior junctional zone into the anterior myometrium and into the serosa with poor fat plane with the bladder. Lesion that is also seen extending into the right parametrium. Cervix and vagina are normal, showing with a few tiny nabothiensis. There is no significant pelvic nodes, so likely we can tell is carcinoma endometrium. BW image, as you see here, it looks very brighter than the ADC infusion and all coefficient. And following surgery done, underwent peritoneal wash cytology plus robotic hysterectomy with bilateral salpingo-oophorectomy plus bilateral sentinel lymph nodes mapping and biopsy done with momental biopsy. Histopath reports tumor size 6 into 7.5 into 5 centimeter, poorly differentiated malignant neoplasm that infiltrating outer myometrium and cervix. LV is seen. 2 sentinel nodes mapped were free of tumor. So pathological staging T2N0. This histopath slide shows sheets of tumor cells in 10x magnification and into 40. IHC cells were positive for P53, synaptophysin and CD56, focally positive for chromogranin, weakly for EMA, CK7, ER, CD10, SMA negative, key 67 index 80%, MSI all 4 IHC intact, suggestive of large cell neuroendocrine carcinoma of endometrium. As showing here, synaptophysin is positive and EMI is positive.
Dr. Sandosh is there?
Yes, I am here, sir.
Can you please come?
Good morning, sir. Good morning.
Yeah, can you please come?
So, am I audible?
Yes.
Yeah, thank you, Pavithran, sir.
Please go ahead. Yeah.
So, this is an extremely rare presentation of an endometrial tumor which is showing neuroendocrine marker positivity, all 3 neuroendocrine, which is synaptophysin, chromogranin, and CD56. And the initial pupil biopsy was showing some glandular features. So I assume that this is a very poorly differentiated endometrial cancer, which has de-differentiated into a large cell neuroendocrine carcinoma in view of presence of glands in the previous biopsy. So a de-differentiation it's an extremely rare, very few cases have been reported. and these have got extremely poor prognosis and outcomes. So we do this panel of IHCs. Unfortunately, in a small biopsy, we don't suspect these, and it's only when we get a resection, the whole tumor is with us, then we do these panel of IHCs. I would have also added a pack set just to look for Mullerian marker and see whether there is some Mullerian marker expression in this.
Follow-up PET-CT done. There is no evidence of disease elsewhere. She was treated with adjuvant concurrent chemoradiotherapy with cisplatin, followed by adjuvant chemotherapy with etoposide and carboplatin. We avoided packing in view of neuropathy grade 1. Follow-up CT abdomen after 1 year, which is normal. Final diagnosis, we can conclude it as large cell neuroendocrine carcinoma of endometrium, stage P, T2, N0, M0. Thank you very much.
A few discussion points were Pabashi or any gynecologist can take up the role of minimal invasive surgery versus open. In brief, you can mention.
Yeah.
That's
So
for the
for
benefit of PGs.
yeah. So for endometrial cancers, there is definitely a role of minimal invasive surgery. In endometrial cancer, even if it is high risk, enough evidence has been there to prove its role even in high risk, high grade endometrial pathologies. But definitely a lot of people do have their reservations when it comes to high grade endometrial pathology, especially this one. But yeah, definitely we didn't know it pre-operatively that the biopsy is large cell neuroendocrine tumor. We thought it is a high grade endometrial cancer. So MIS can be done. But if we had known it pre-operatively with the help of IHCs that it is large cell neuroendocrine, I might not be very comfortable doing it MIS, and definitely not very sure about the role of sentinel nodes in a complete lymph node dissection. But otherwise, in all high-grade tumors, even sentinel nodes are sufficient enough, provided you have enough expertise in that technique.
And role of sentinel node?
Yes, role of sentinel node in high-grade endometrial pathology is there. There is enough evidence for that. The Shrek trial has come, which has shown equal evidence for sentinel nodes in high-grade. But in large cell neuroendocrine tumor, there's not much evidence. So I would prefer to go ahead with a complete lymph node dissection, that is a systematic pelvic and parotid lymph node dissection in a case of large cell neuroendocrine tumor instead of a sentinel node biopsy, and definitely a preoperative PET-CT.
Yeah, especially in this case, because it's a...
Especially in this case, yes. So the role of preoperative IHC is very important in this case, especially when we knew it's a poorly differentiated tumor.
Yeah.
I think Dr. Santosh is a better judge for that. Yeah, because if pre-op pathology is there,
I
we
think
weren't aware of it.
I think if you have a diagnosis of pre-op, I think the pre-op biopsy we did not have any IHCs, we would definitely have done an IHC. So when we have a poorly differentiated neoplasm in a biopsy, we would definitely, the broad categories always come as lymphoma, melanoma, and carcinoma. So obviously, if it's endometrium, we would think of grade 3 endometrial adeno versus an undifferentiated, dedifferentiated, and endometrial stromal sarcomas. These are the thoughts when we see a very poorly differentiated malignant tumor on a biopsy. So IHCs we routinely have to do on biopsies to try and delineate. And
because the entire plan will change probably if we are aware of these tumors. Probably the entire planning will change. Like we will do a PET-CT, which we usually do not do for an endometrial cancer, and obviously the lymph node staging itself will change.
Can I add something, Dr. Pavithran?
Yes.
Yeah, well said, Dr. Pavasi. Just one thing regarding this case, as per the presentation when the case presented. So in the MRI there was parametrial invasion, and there are loss of fat planes with the bladder. So ideally, in these cases, what we do that we do a EUA, because we don't know that it's a neuroendocrine tumor or not. It's a high-grade endometrial carcinoma. So whether we'll be able to do a upfront surgery or not is important. So for all cases of CA endometrium with a parametrial invasion in the MRI and a loss of fat planes with the bladder with the serosal breach, I think it would have been better that one should approach with a examination under anesthesia, be clear that they will be able to perform the surgery and then go ahead with the surgery, and whether to do MIS or a open, I think as Dr. Pavasi told, it's reserved for the surgeon and the institute.
But in the poster findings, there was no, it was confined to the endometrium only. It was not.
Yeah, but preoperatively.
Yes, definitely. And regarding the further adjunct treatment, Dr. Nishita or Dr. Seema is there?
Yeah, I am there, sir.
Yes, please come.
This is Dr.
On the
Nishita
further
here.
adjunct management. Yeah.
Yes, so the data on large cell neuroendocrine C of the endometrium is very limited. So I think we extrapolate the data from other
Yeah.
C endometriums or maybe the neuroendocrine tumors of the cervix, because the numbers are more in, at least in cervix, compared to endometrium. So we know it's a poor prognostic disease. So we would give almost everything to the patient, even if it is early stage. So adjuvant radiation as well as chemotherapy, because they've shown that people who have received chemotherapy, they tend to do better, even if it is earlier stage. And as told earlier, in case if we had a prior IHC pre-op, we could also have given neoadjuvant chemotherapy in such cases, which will also tell us the disease biology. Although the data is limited, but there is some data in large cell neuroendocrine carcinoma of the endometrium in case if surgically it is not very operable upfront.
I really beg to differ in that, because if she's operable upfront and the disease-wise
Yeah,
status
not
is
if
good,
she's,
I think there
if
is
she's
no other
operable
disease
upfront.
anywhere. Yeah. Yeah.
Yes, yes. Because the MRI wise, it was a little bit extensive baseline.
I will summarize here. As mentioned already, it is a large cell neuroendocrine carcinoma is an extremely rare malignancy, and only less than 45 cases reported so far, and 15 were pure large cell neuroendocrine carcinoma. And it is a difficult diagnosis to make, and these tumors are often mistaken for poorly differentiated carcinomas, and survival is poor, and usually treated with a multimodality approach like surgery, radiation, and chemotherapy with usually platinum and etoposide. So thank you.